patients. Who's been here when somebody's fainted? Who's been here when somebody's fallen down and go boom? And it's happening a lot because we have a lot more people in the building. Well, we are very lucky this evening to have Dr. Del Rio. He is the medical director at Meast Dunedin. He's also an emergency room medical doctor that's going to go over the finer points of how to deal with, what we mostly deal with, of course, is heat exhaustion, but a few other things so that everybody has the basics. After he finishes, Maddie has an incredible form, and she'll go over all of that, of our first aid procedures, so that everybody is on board. The good news, too, is as you can see, Joe Malo is videotaping this. Hey, everyone. And so please express to your other team members to get onto our website. We'll also give you that website address so that they may watch it as well, and they will also become educated about this. So here is Dr. Del Rio.
Hi, thank you. I gave this talk earlier today. Hopefully I can do it as well. Mike Hurst asked me to come and talk to you all about some of the basics of emergency care. And what I was thinking about was you're only really going to see a couple different things here. And you're going to be charged with the most important thing is identifying the sick patient. And I talked this morning about sick and not sick. And for the most part, I think all you all will be able to tell what's the difference between sick and not sick. Sick is going to be someone who is knocked out unconscious, profusely bleeding, things like that, where the not sick is going to be someone who maybe got a little faint, needs to sit down, sprained an ankle, something along that order. So when dealing with the sick patient, I would basically say those people will fall into two categories, where they're a fainting spell or a not fainting spell. Okay, or near fainting spell. The fainting spell can run the gamut of medical problems, from a stroke, from a heart attack, from electrolyte abnormalities and arrhythmias and the sort. So in that patient, or that, excuse me, that customer, the person who is fainted and is unconscious, I would expect you all to do first things first, that's called 911. The next thing is going to be assessing that patient, that person. You all have an AED here, and that should be part of the plan in place, that when a patient goes down, that is brought to the patient's side, the customer's side, as well as any type of first aid box that you might have. And when you have that patient, you want to assess them in the most basic form that we have in emergency medicine. It's an easy way to remember. It's the ABCs, okay? And that stands for airway, breathing, and circulation. And back in 2010, the American Heart Association came out with new guidelines for CPR. And they kind of changed a little bit to have it say circulation first and then airway and breathing. And the reason being is the most common cause of cardiac arrest is ventricular fibrillation. And that's not treated with CPR, that's treated with electricity. So that's why they really wanted people to get into the habit of putting the pacer pads on and clicking the machine on to find out if this patient was in a shockable rhythm. I would still stick with your ABCs in this scenario. The reason being is you have time to, you're going to have a time lapse between getting the AED next to them, bringing it to the patient's side, and also waiting for EMS. So you're going to have time to assess the patient. And by airway, I'm talking about a pure mechanical thing. Okay, airway is just purely mechanical. That's blood in the mouth, vomit in the mouth, the tongue is falling back, the patient has had an allergic reaction, the tongue is swollen. Okay, so those will be airway issues, and you want to open the airway. Okay, the other thing, breathing, would be next, and that's going to be determined by someone's chest rising. You hear breath sounds with them breathing, and then lastly is going to be checking a pulse for circulation. Okay, and you can actually do several of those things together at the same time. If I see you sitting on a bench talking, A's and B's are done. You're talking, you're breathing. Okay. The next thing you're going to do is touch their wrist and check their pulse, check their neck, something along that line. in the person that has passed out, okay, has fainted and is totally out, there's a couple of things you have to be cognizant about. And one of them is an injury to their neck, okay? So if they just flat out did a face plant and whacked their head, whacked their chin, fell straight back and hit their head, that person may have a spine injury, okay? So it's going to be important to stabilize their head and hold it in position. And basically, if you can think about, we call it inline stabilization, and if you think of the spine running straight up, you just want that head to be straight, okay? So if they're turned to their side, you're actually going to have their head like this. Okay. Some of the other issues that you have to worry about is a patient that may be seizing, okay? Now, it is very common for a person to have a fainting spell and seize. That's not a big deal, believe it or not. It's because the patient's blood flow to the brain stopped and they had a small seizure. That's not a big issue. The issue is the person may vomit when they seize. Okay? So it's very important to turn those people onto their side so when they do vomit, everything comes out. Okay? And if there was an injury involved in that, I would ask that you hold their neck in place while you turn them to the side. Once the seizure is stopped, once the vomiting is stopped, it would be safe then to roll their whole body and neck and head back together as one, back onto their back, and wait for EMS. The person with a pulse under 100, I don't think, the strong pulse and they're coming to, I don't really think that you would need the AED patches on them. I think that would be reserved for the patients that are knocked out unconscious or unresponsive and you don't feel a pulse or you feel something racing over 100. Just because you put it on them doesn't really mean that it's going to shock. The system, I don't know if you've all been trained on it, but it's fairly simple to use. You open it up, you pull the tab, and you pull out the pacer patches, and it tells you where to stick them. You stick them up here and right on the side here, and then you hit the button, and it starts to assess the patient for an abnormal rhythm. And then you can listen, and it will say, this is a shockable rhythm, stand back, blah, 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 hit the button, boom, you're done. If it's not, you can hit info, because that means that it's not a shockable rhythm and you need to start doing CPR, and the machine will actually start walking you through CPR. Okay? Yeah?
I believe this machine is pretty dummy-proof, but let's just hypothetically say in the panic of the moment somebody hits the shock button. Will it shock?
I don't know if your system, I don't think it does. I think it has to be a shockable rhythm. That would be V-fib, V-tac, torsades, maybe a fib, but I don't think they will.
And I was going to say, I was pretty sure that when I read through the book that it basically said that it would not shock unless it identified that it is.
Right.
So when
But beyond that, I don't think it's charged unless it's a shockable rhythm. So it's impossible to discharge electricity. And that being said, if you had a shockable rhythm and it said shock and it changed, it may even, stop itself from doing that. So I don't think there's energy deliverable if it's not a shockable rhythm. So that's not a worry about, touching them and going, oh geez. So, and everyone should always step back away, make sure, you have to be very careful, there's a lot of water here. Water is highly conductive, so you have to be careful about where you're standing, where there's water on the ground and whatnot. What else? So the AED is very simple to use, okay? It was made like that to have non-medically trained bystanders be able to use it. So it's pretty self-explanatory with nice big pictures, nice big writing, and also verbal stimuli to get you through it. Yes?
Let's say that this happened up by Nicholas and the person had just been splashed. Is it still safe for us to use an AED in that situation?
It would still, if they're splashed, I would try to dry them off as best as possible, because water on their chest may drip down and be on the floor and things like that, and it could provide enough of conductive element to transmit some of that energy. Okay? Because in the hospital, we have a bunch of wires, and they're not necessarily touching the rails of the bed, but all the wires as they come off the patient onto the, so everybody just stands back, and you'll see everybody get back about a foot because they don't want to get a secondary shock. So, So in the assessment of, going back to the assessment of the fainted person, if they come to, like I said, I don't think the AED is going to be required. It's going to be, you know, are you hurt? What's hurting you? I would still call 911 in someone that actually fainted. Okay, I would err on the side of caution and call 911 for most instances, unless it's a simple, you know, trip and sprain an ankle or something like that, and they're fine and they want to go home. They don't want a doctor or something like that. But anyone who faints, I think, probably should require EMS to at least evaluate them, and they're able to deny or refuse care from them. It was a real big issue today, or topic today, about giving the patient or giving the customer water, because a lot of times, like as someone said earlier, that this is very often related to heat exhaustion. If the person felt lightheaded, I gotta sit down, I wanna sit down, you walk them to a cool room, you sit them down, I'm so thirsty, I'm parched, I want water, give them water. I know that the EMS and 911 have been like, don't give them water. For the life of me, can't figure out why. Okay, and a person who's awake, alert, and talking and requesting water, give them water. All right? I'm not going to do emergency surgery on this person, so give them some water. All right. Are there any other points that I missed from earlier today?
No, one thing we were going to talk about is when is it safe, or when do you move that person? So as, you know, if somebody passes out, we assume it's heat exhaustion, it's upstairs on the next pool, it's hot, it's sunny. You know, do we need to, when is it safe to move that person?
If you have determined that there's no significant injury, mechanical injury, you know, after the fall, then I think it would be okay to move them. Someone who you suspect sustained a significant injury to their head, because that's really the only thing, we can't really tell too many times of a neck injury, say, but we can find a big goose egg or split open head or split open chin. You have to assume that the person may have, especially when they're obtunded or unresponsive, you have to assume and treat them if there's an underlying neck fracture. So I would say those people stay put and wait till EMS comes. Okay, the person that comes to is groggy, is like, oh my gosh, what happened? You know, I just flew from LaGuardia and drove from Orlando with 250 people in my car. You know, and you know, he's saying those things. Get him up, you know, with assistance, and get him into a cool room, get him some water, call 911, and let them deal with that.
Okay, let's take that out a little bit further. So let's say we have somebody, they pass out, they fall down, we could have been an injury, we don't know, but then they come to, they want to get up.
Tell me that again, I'm sorry.
So they passed out, they fell down,
Yeah.
they you know, somebody witnessed it, they did it straight back or straight forward, so we can't rule out that there's not any internal injuries.
Right.
But then they come to and they want to get up. Let's say we've got an employee holding C-spine, and they kind of come to and they're kind of fighting or they want to get up. Do we let them get up? And this follow-up question to that is, if somebody passes out, they're laying there, we probably need to talk about, do we put an ice pack on them? Do they give them water? If we opt not to move them, we're waiting on the EMS, what should we do to make that person comfortable?
The person that you're immobilizing, you know, does not need any ice per se, because EMS is coming and they're going to whisk them away. The only thing I could think of would be ice on a bump on the head or
So
something
no
like that.
ice packs, because we do ice packs.
No, you can, definitely. I think it's a great idea in general. But I that's not an emergency for that person that passed out and EMS is coming. So the person who tripped, and yeah, give them that. The person who had a near passing out spell, tripped and hurt their ankle, give them some ice, put them in a cool room, give them some water. Those kind of supportive measures. Okay. The person who is passed out and you're holding C-spine mobilization, I would not worry about icing him
But
down.
we use ice packs to cool the person down a lot.
You can.
Okay.
I mean, I'm not going to say, but I would say that's not a priority.
Okay, good, also it's fine.
Don't you guys have an ice machine and some Publix bags? That's all it takes. That's what we use. So, to answer your question a little further, you know, that person that wakes up and may or may not have had an injury that says, my neck's not hurting me, then I will probably err on the side of saying, okay, try to move your neck, does it hurt? Then you're probably okay. Okay. It's the person who remains unresponsive, obtunded, that you're going to do that until EMS arrives or till he wakes up. You know, we talk about distracting injuries or some other condition that could distract the patient from realizing that he has a neck fracture. And that would be a long bone injury, so he's got a broken leg. You know, his ankle is twisted and crooked sideways or something like that. Those would be distracting injuries. Like, only thing I can think about is my foot, man. I don't even feel my neck. That person may have some. Or then I'm hoping you don't get as many as we do, but the inebriated patient, the intoxicated patient.
We've had two.
Two? We got two in the ER right now.
Should we be influenced at all by what the person down on the ground looks like, flushed and sweating profusely versus pale and dry?
Well, pink and warm is always best.
Okay.
Pale and cool is bad. Okay. And remember, most of these are going to be what we call vasovagal syncope or simple fainting spells. And basically, you have an overdrive of your nervous system, and it shuts down all the blood flow to the skin, so you're going to look pale, and then the heart's going to kick back into gear, and you're going to get, you know, back red and pink and warm. You know, the person who starts sweating and it's not a hot day, that's always a concern. That's someone that may have gone into a fatal rhythm or an abnormal heart rhythm that caused the passing out spell, where the typical fainting spell, the swoon, is from the heart rate slowing down rapidly, blood flow decreasing, because blood pressure decreases, no blood goes to the brain, you pass out, you hit the deck, the heart kicks back into gear, and then you wake back up. That's the common scenario.
Doctor, you mentioned calling 911 first.
Yes.
Suppose someone passes out and they come to. Should we try to say, you know, do you know where you are, what's your name, that kind of thing, or should 911 be the first? That's what we do when somebody calls.
Oh, I have no problem with you doing that. Are you know, asking the person if they're okay? You know, I look at it as like, you know, there's a lot of, you know, helpful people here, it looks like. And as you hear something happen, it should be on the radio, it should be to a partner. Go call 911, I'll take care of the customer. And then that person is going to be doing that assessment. That assessment always is going to be, you know, hello, what's going on? Oh my gosh, I don't know what happened. A's and B's are done. Okay, move on to circulation. Feel their pulse. You know, most likely you're going to feel a really slow pulse. You know, boom, boom, something like that. If it's going really fast, like over 100, then you may want to consider putting the AED, because they may have gone into an irregular rhythm that might be shockable. If it's VTAC, and not so much that it's going to be shocked while they're awake, you know, but they may pass out because the rhythm comes back, and you'll shock them at that point. The machine will tell you to shock them at that point, I should say.
So if anybody has any other questions, Dr. Del Rio needs to get going. Can you just email them to me, and I'll make sure that he gets
I
them?
have 15 minutes or so. So.
We don't.
Oh, okay.
And let me just make one statement kind of back to that question, is that from CMA's perspective, it's really preferred that you call 911, because that helps us on the liability piece. But to your point exactly, is that if you were the first responder, you need to be assessing the patient, and then you need to point, and you need to point and be specific who you're pointing to. You, if you don't know their name, I want you to go call 911. That way you've already designated, or Anna, please go call 911.
That somebody is making that
So
move
somebody's
first.
making that call, and at the same time, you should probably say, especially if you think the AED is required, or it needs to be one of those things we have at the patient's side regardless, then you designate somebody else, I want you to go get the AED, and that way you stay with the patient.
And we've got all that covered. Maddie's going to go over all our procedures here at CMA with Dr. Del Rio's advice on putting all that together. So that's.
So it sounds like there's really two situations where you would use AED. One would be if they're awake, the AEDs are okay, but circulation is over 100.
The pulse rate is
The
over
pulse rate's
100.
over 100.
And if they're still like kind of grogging out of it, I don't think it's a bad idea to possibly put it on. I'm not gonna. It's gonna be on a situational basis.
Right.
Okay.
And the
If
other
they're
one is where they're completely out.
completely out, I probably would put it on them. Okay. You can check for a pulse if it's strong and 50. You're not going to use the AED. Period. I know that. Okay. They may have had a seizure, they may have just passed out and bumped their head and now have a bleed. But then we're going to go into a bunch of emergency medical things, like the person had a stroke, the person had a ruptured aneurysm, who knows? A bunch of different possibilities exist. So it's going to be the person that is, without fail, the person that is passed out, unconscious, unresponsive, and has no pulse gets the AED, period. You got a pulse, you saw what happened, they're moving some things, and they got a pulse, the AED is probably not going to be useful. This is for pulseless cardiac arrest, is what it's useful for. And believe, it's pulseless, but the heart's beating. That's the thing. Because remember, and people don't understand this, when that flat line happens on that recorder that you see on TV, electricity doesn't help that. Okay? You don't shock that. What you shock is this, the heart doing craziness. All right? But that is not transmitting blood through the body because it's a fatal rhythm. So that's what you can't tell because you don't see them on a monitor. So the person that does not have a pulse gets the AED to determine that. There are some other instances, like I said, with over 100, I would say, I don't think it's a bad idea on a case-by-case basis to put it on there just to see if it's something that might be shockable if it happens again. You understand? So.
One last thing, is there ever a situation where you cancel a 911 call once it,
I don't.
you got to let it play through?
Call 911,
Okay.
they're coming. So
And they can
Dr.
hash it
Dorian,
out.
do we all get our nurses badges now?
Yes.
Thank you so much for doing that. This is Dr. Del Rio, and a lot of hard work from Ann and Maddie. We have put together a very simple how to and what to do if there is a circumstance here that requires some medical attention. Up until now, what's been happening is, let's call hospitality. We don't want that to happen. One of the reasons is because hospitality could be running around all over the building and difficult to find, and you're losing valuable time. So we want every single team member to know exactly what to do. Maddie's going to go over this form that she's handing you guys right now, and then also know that those are going to be blown up and posted in various places around the building. So Maddie, you want to take it from there?
Certainly. All right, well, as you just heard from Dr. Del Rio, there's a lot that can happen, and it can be kind of tricky to keep track of what you should do in specific situations and where everything is around the building. So that's basically why we made these sheets, is just so that everyone, will know where the first aid boxes are. That's always a biggie. Where the information sheets are kept, so that you'll know. Yes. Yes. So this sheet, and it does have a reverse side as well. I know it's easy to forget. Everybody have one so far? Okay. So this sheet is basically, one more? Okay. Oh, Lauren's got it. So this sheet is basically just to take away the mystery, make sure everybody knows where everything we might need is located. So if you look right underneath the title, First Aid Basics, you'll see we have the locations for the first aid kits. Now tomorrow morning, we're going to revamp these kits. We're going to make sure personally everything that we might need is in them. And you'll see that locations 3 and 4, we're going to have large blue bins that are going to be located underneath the bleachers at Dolphin Terrace and out at Sawyer's Passage. They're going to be a little bit more weatherproof that way than the little teeny first aid kits we have there now. Now what we're going to have as far as where the sheets are posted, that's the second column there on the right, pretty much everywhere that we can think of. Pretty much every office, the classroom, the theater, the break room, by the hospitality board that everybody's probably stared at one time or another while waiting for the restroom. We'll also probably have those inside those big first aid bins. Our goal, we want to really hit you in the face with this so that if something happens, it's not a, oh my goodness, I forget, what do I do? It is right there, or you've been looking at it 15 minutes ago in the hallway. So we're going to try to have this pretty much everywhere. And you'll see we've tried to break it down underneath how to handle fainting, depending on whether the guest is conscious or not. We tried to keep it pretty simple. Obviously, there's a lot of detail that we could go into, but we didn't want to inundate everybody. You just heard Dr. Del Rio say the most important thing is to assess if 911 needs to be called, which is almost always going to be the case if the guest goes down. We also have, as he mentioned, it's especially important to note how the guest falls. If they're sitting in a chair by the winter zone and they kind of slump over, that's a little bit more of a gentle fall. They might not have as much head trauma. If they, as we've all seen, if they're standing up and they do a nosedive or back, we want to make sure that we don't move them, just like you said, unless we know. We can ask them, hey, do you feel okay? Does your neck hurt? Does your head hurt? We can kind of use that to assess. Because again, like you said, we don't have those machines. We can't tell if something's wrong. We're going to have to rely on what they tell us. So communication with them is going to be very important. On the bottom of the first side, we also have how to handle the other assorted incidents. The most common ones are the injuries, if a guest trips, if they sprain their ankle, if they're bleeding in some way. We have the tips for how to handle that. And along with heat exhaustion also comes vomiting. So we do have that column there about how to handle it in that situation. So if we
Can I
take
just say, we have a facilities department that cleans up vomit. That's not part of the hospitality. Just to let everyone know that. Somehow that's a word got around about 2 years ago.
Good point, Anna. And so next time you see Brad and he looks frazzled, give him a hug because he's probably had to do that. So if you take a look on the reverse side, you can see we have a couple very important reminders up there in red. Now first, whenever we call 911, and especially on busy days, we're going to designate a volunteer. You, again being very specific, you go outside, flag down the ambulance. Otherwise, there's people out there in line. Where are the ambulances going to go? Where are they going to park? We need to get them up here as soon as we can. So we're going to have a volunteer. And you've probably seen Brian do this. He's a champ. He's running out there. He's waving his arms, and he's bringing them right in and taking them to where the guest is so that we can get them treatment as quickly as possible. Otherwise, they're standing out there. They have no idea where to go. So that's a very important thing, is somebody's going to probably be designated to go flag in the ambulance. Now also, we're going to keep an emergency water stash. It's going to be labeled as such. So please, unless you yourself have heat exhaustion in the break room, leave the emergency waters for us. We'll also keep some, again, in those big first aid bins that are underneath the bleachers, so that if we need water, it's not going to be very cold, but it's going to be readily accessible, so that we can give them sips to keep them hydrated. We also have some little reminders about when it is appropriate to use the AED. And again, Dr. Del Rio mentioned, it really does actually speak to you to tell you directions on what to do. When you turn on the AED, I know before I took the class, I was terrified. Why would I use this thing? I don't know how to use this thing. It actually has a human voice that will talk to you and tell you where to put the pads. Push this button to analyze. So it really is very simple. It'll walk you straight through it, and these tips will help you remember that. Now, any time that we do have to administer first aid, an incident report has to be filled out. So that's when you'd want to make sure that hospitality or guest services is involved so that we can take care of those reports. Now, you can get started on those reports. They also are going to be in those bins. Now you see why we need a bigger size of those bins. So we'll have those in the bins on clipboards. Now, when you're getting started, the first parts are, the name of the patient. When did this happen? The more detail you can take down, the better. Is it a child? Is it an elderly person? Anything that you can think of that might be relevant to the EMTs when they arrive. The more information you have, the better. So that's definitely good to remember. You can see there we also have all the relevant phone numbers that you might need. 5 Hospitality, Elena is going to be for DTA, so I put her on there in case something happens there. It's air conditioned, but accidents happen. We also have the guest services phone numbers and Brad and Vic for the unfortunate situations involving cleanup. So all the phone numbers that you should need are there. So then we have the little squiggly line, and underneath that we have 2 websites that you all might find pretty helpful. We have the hospitality website, so the address is right there for you. The first aid sheet, it's only 1 sheet on there. It is posted on the hospitality website underneath safety. So you can see it online at any time. There's really no escaping it. We also, courtesy of Lauren and the education team, we've provided the education training site. And that kind of goes back to our earlier topic of dealing with the guests. Being informed, which I know you all are, about the animals and where they are. But there's more information on this site that could be helpful if you're interested in going to the site, checking it out, just to give you some extra talking points with the guests. So I think that about covers first aid. So nurses' badges. George, go ahead.
How do we get the people out back to the EMS vehicle? The reason I bring that question up is we had an incident on the 2nd level, and it's took almost forever, it seemed like forever, because all the people were running around, to get the ramp unlocked and the locks taken out so they could actually wheel the stretcher that this person was on back down to the ambulance, and it was frustrating, we were almost ready to carry the stretcher down the stairs, but then finally someone came up with the key. Is there any way to kind of streamline that
I can
process?
see Frank taking notes, so I'm sure that's something he's
To-
gonna
to actually,
address.
we've done
regarding
everything, the person
being able to have
strapped into the
access.
gurney.
We'll talk to the safety department about that
All right.
and work on that.
And in the meantime, I mean, it will be addressed very quickly, but that's one reason that we provided all of our phone numbers. Is I know everybody, almost everybody carries phones on the floor. Have our numbers in it so that if you need us, instead of playing where's Anna and where's Maddie around the floor, because we know that can take 15, 20 minutes, call us. You know we've got our phones on us. If you call us, 2 minutes and we'll be there. So that's a good way until we get it better set up.
Where's the AED?
The AED is actually on the second level, right outside Frank's office.
Is that
So it's a strategic location. At his request. Maybe.
Maddie, what's the liability with, say myself, I'm an untrained person in first aid. I may have good responses, but nonetheless, I'm an untrained person, and I'm compassionate, I want to do the right thing, but where's the liability? Because the person could turn around and say, well, you know, you didn't support my neck, it was your fault that I have this, or something. Do you know what I'm saying? Something
That's a
could
good
happen, I'm
question.
not trained.
Isn't there Good Samaritan
Samaritan.
exemptions?
We actually have an attorney, Catherine Bischoff, right here. Would you like to speak to that, Catherine? We've been told that that's.
You're an untrained person, you don't have any liability. I can't tell you that nobody's ever going to sue you because everybody likes to sue, but you're an untrained person, there is no liability.
Does-
We have Good Samaritan laws here in Florida. If you stop to help anyone, you're protected.